Good evening. At the outset, I would like to thank my alma mater for allowing me to be a part of Manipal Update 2020. And the topic on which I'm going to speak is what is new in atrial fibrillation in 2020. And my topic is totally derived from the latest publication of ESC guidelines for the diagnosis and management of atrial fibrillation by the European Society of Cardiology. Now, the class of recommendations and the level of evidence is well known to everybody, so I would not go into it. Definition of atrial fibrillation. We all know it's a supraventricular tachyarrhythmia which needs to be documented on an on a 12-lead ECG for at least 30 seconds, and it should show a irregular RR interval, absence of distinct repeating P waves, and this should be definitely for at least 30 seconds on an entire 12-lead ECG. Atrial high rate episodes are important because they are used to diagnose subclinical atrial fibrillation, especially in patients who have CIEDs like pacemakers, defibrillators, or implantable implantable loop recorders, and these help us in identifying patients with subclinical AF, and it is important for decision making for whether they need to be on oral anticoagulants for thromboprophylaxis. Now, definition of atrial fibrillation: it is diagnosed as first diagnosed irrespective of its duration or the presence or severity of the AF related symptoms. If you have seen the patient for the first time and he has never been diagnosed to have AF earlier. Paroxysmal atrial fibrillation is anything that lasts less than 7 days, even if it is terminated within 7 days by intervention. Persistent atrial fibrillation is something that lasts more than 7 days and less than 12 months. And long-standing persistent atrial fibrillation is anything that lasts for more than 12 months, although a decision on rhythm management is still on. If the decision has been made that the patient would have to stay with atrial fibrillation and only rate control is the option, then it becomes a permanent atrial fibrillation. The terminologies like lone atrial fibrillation, valvular, non-valvular atrial fibrillation, and chronic AF should not be used and should be abandoned. This I've already described how to diagnose atrial fibrillation, and this is a class 1 indication. And once the diagnosis has been made, initial assessment for stroke risk, symptom status, burden of AF, and evaluation of substrate should be done based on age, genetics, ethnicity, male sex, and all other factors that can lead to increased hypertension, increased atrial fibrillation, in addition to the factors which can cause increased risk for stroke should all be looked at, and based on that we should decide whether the patient should be taken up for further screening of atrial fibrillation. Once the decision has been taken that this patient needs to be taken up for screening for atrial fibrillation, it should be clearly described to the patient what is the significance and treatment implications if AF is detected, and a structured referral platform should be in place in all the institutes. Definition, of course, we have already described it twice earlier, and this is a class 1 indication. Various systems that can be used for screening atrial fibrillation have been shown here, and each one of them have their own benefits, and they should be looked into before deciding on which parameter is being used for screening the patient. Once the patient has been diagnosed atrial fibrillation, then an integrated AF management is what we need to look at, and this should be patient-centric. The most important aspect is optimized stroke prevention, following which the symptom control with rate or rhythm control and management of cardiovascular risk factors come in, and this includes lifestyle modification and psychosocial management. You can clearly see here that integrated management of atrial fibrillation does not only involve a cardiologist, but involves many other specialities, including people who are not a part of the clinical spectrum, like pharmacist and AF nurse. Although these are more applicable to the Western world, but definitely many centers in India are also looking at managing patients in this way. So integrated AF management is class 1 indication, and all these PROs should be in place when you are doing atrial fibrillation management. Once the AF has been diagnosed, the first and foremost thing that we need to do is thromboprophylaxis. And in this, we need not only look at the CHADS-VASc score, but also Hasbled score should be looked at, and modifiable bleeding risk factors should be looked into, based on which the management of the patient should be done. Initial decision, if taken for oral anticoagulation, should be relooked at regular intervals, and this is a class 1 indication. In this slide, you can see that there are non-modifiable, modifiable, and potentially modifiable factors which need to be looked at, because these can increase the chances of bleeding in a patient. And once you have diagnosed or identified potentially modifiable or modifiable risk factors like hypertension, excessive alcohol intake, bridging therapy with heparin, or extreme frailty, anemia, these should be aggressively managed to decrease the risk of bleeding, so that the patient can be managed on uh, oral anticoagulation for a better stroke prevention. So, decision of stroke prevention has been taken. Look at whether the patient has prosthetic mitral valve or moderate to severe aortic stenosis, mitral stenosis, and put them on VK if yes. If no, look at the CHADS-VASc score. If it is less than 0 in males and less than 1 in females, they do not need antithrombotic therapy. Relook at the spectrum after, let's say, 5 to 6 months, and then decide whether they need to have it in future. If they have a CHADS-VASc score of more than this, then look at the Hasbled score and the modifiable bleeding risk factors, work on them, and then start on NOACs, which is a class 1 indication, especially if patients have a CHADS-VASc score of more than 2 or more than 3. I would say anybody who has more than 1 in males and more than 2, I would possibly go for NOACs in those patients. So what you can clearly see here is that 4 to 6 month revisiting of the CHADS-VASc score is a class 2A indication, and estimated bleeding risk in the absence of absolute contraindications to oral anticoagulation should not in itself guide treatment decisions. Clinical pattern of AF does not decide thromboprophylaxis. It is class 3. It is only the CHADS-VASc risk score based on which you should always decide whether the patient needs a thromboprophylaxis. Prior to cardioversion, what all things we need to look at is first that the patient, if he has hemodynamically stable atrial fibrillation, then he should be cardioverted only after considering the thromboembolic risk. And if the patient has sick sinus syndrome, atrioventricular disturbances, conduction disturbances, or prolonged QTC, pharmacological cardioversion should not be tried on them. Now, catheter ablation. This is something very important and very aggressive in Western world. So what are the indications for catheter ablation for rhythm control? This should be, first of all, decided after a detailed discussion with the procedural risk and major risk factors having been looked into, and the patient needs to be explained in totality about the procedure. And this is a class 1 indication. Repeated PVI procedures and procedure of atrial fibrillation ablation in patients who have failed a therapy of antiarrhythmic drugs, it is a class 2A indication to do a AF ablation. You can see in persistent atrial fibrillation, it is a class 2B indication, and additional lines or other fragmented activity or ectopic rotors to be targeted is again class 2B indication, and they are still not very much things which need to be propagated. So indications for catheter ablation of symptomatic atrial fibrillation, you can clearly see, first of all, the patient needs to be explained about the choices, and only after failed drug therapy it becomes a class 1 indication in paroxysmal or persistent atrial fibrillation. In patients in whom there is a heart failure and tachycardia cardiomyopathy is a possibility, in that is the group of patients, it becomes a class 1 indication to do a catheter ablation after explaining the choice to the patient. Else, if the patient refuses, you can go for antiarrhythmic therapy, and if that fails, you can again go for catheter ablation. So class 1 indication is only if you are thinking of tachycardia cardiomyopathy with atrial fibrillation, or if the patient has antiarrhythmic therapy, at least one set of drugs. Lifestyle modification is a part, and avoidance of triggers is a part which needs to be aggressively looked at and taught to all the patients, and this is a class 1 indication. Now, stroke risk management, pericardioversion, you should look at the NOACs as should be on board before cardioversion, especially if it is more than 24-hour AF duration. The patient should be on anticoagulation for at least 4 weeks and should continue it for another 4 weeks post cardioversion. I have already talked about lifestyle modification. It is class 1 indication, and this includes aggressive treatment of hypertension, hyperglycemia, stopping smoking, alcohol, physical activity needs to be increased, obesity and obstructive sleep apnea should be looked at with aggressive management. If the patient has atrial fibrillation of less than 24 hours and his CHA2DS2-VASc score is less than 0 in men and less than 1 in women, then the post cardioversion anticoagulation may be omitted, but it is class 2B. So for all practical purposes, I would anticoagulate a patient post cardioversion for 4 weeks, whatever be his CHA2DS2-VASc score. Recommendation for stroke risk prevention in pericatheter ablation procedures: you have to have the patient on oral anticoagulation for at least 3 weeks before ablation. Or else class 2A, you can look at transesophageal echo and exclude LA thrombus before ablation. But the patient should be on NOACs preferably, and the ablation procedure should be done without interrupting the OAC. And this is class 1 indication. The patient should be on oral anticoagulants for at least 2 months post procedure. Now, long-term antiarrhythmic medications, sotalol should be used only if we can closely monitor the QT intervals, serum potassium levels, and creatinine clearance. In patients who are on flecainide, AV nodal blocking drug should always be added, and this is a class 2A indication. So when you look at long-term rhythm control using medications, you can clearly see if the patient has no structural heart disease, possibly drugs other than amiodarone should be used because of the side effects of amiodarone. But if the patient has heart failure, significant valvular disease, flecainide is out, you cannot use it, and amiodarone is in. But patients who have reduced ejection fraction, you only have an option of amiodarone or catheter ablation, especially if you think that the patient has tachycardia cardiomyopathy. This is very important. A very important subgroup of patients of atrial fibrillation who have ACS, a PCI or a chronic stable angina is present. In this group of patients, it is a very well documented guideline now that the patient should have triple therapy for at least 1 week, and at that point of time a decision on whether to stop aspirin can be taken, especially if the bleeding risk is very high and thrombosis risk is low. Else it should at least be continued for 1 month, following which a NOAC plus a P2Y12 inhibitor can be continued for 6 months to 12 months based on the risk profile. If the patient only had fibrinolysis done, then aspirin is out and the other thing pretty much remain the same. Similarly, if the patient is on VKA, then INR should be maintained between 2 to 2.5, and rest of the therapy is the same as I had described for NOACs. Before deciding on of triple therapy or double therapy, we need to look at the thrombotic risk factors and the bleeding risk factors and weigh them accordingly. And based on these two, you should actually decide. And of course, the access site bleeding or access site is also important. And based on these parameters, one should decide whether the therapy needs to be continued for 1 week to 1 month, triple therapy, I mean, or double therapy for 6 months to 1 year. So at the end, I would basically like to conclude by bringing out the differences between the 2016 and 2020 guidelines. The first difference is that the integrated AF management has been upgraded from class 2A to class 1, where we need to have a good understanding of how to manage the AF as an integrated approach involving multiple departments and having it as patient-centric approach. Bleeding risk assessment with identifying modifiable, non-modifiable, or partially modifiable risk factors have also been upgraded from class 2A to class 1. and their attention to them needs to be looked into. Thromboprophylaxis using NOAC has been made class 1 from class 2B, and if NOACs cannot be started, then TTR should be improved in patients who are on BKA. AF catheter ablation has become class 1A indication from class 2A indication, and the indications in which it is specifically class 1, I have already described them during the previous slides. Of this, I have already described that the patient having tachycardia cardiomyopathy, it becomes a class 1 indication to go for catheter ablation for rhythm control. Complete isolation of pulmonary veins is class 1 indication. Doing a CTI ablation is if the patient had a documented flutter, has been downgraded from class 2A to class 2B, that means it may or may not be considered to be done. Weight loss has been upgraded from class 2A to class 1 and has been included in the integrated approach, where NOACs recommended with at least efficacy and safety as warfarin before a cardioversion has also been upgraded to class 1. After AF ablation, I have already described that 2 months of post-ablation NOAC has to be continued, and this has been made as class 1 indication. And long-term continuation of systemic anticoagulation does not depend on the success of the procedure. It basically depends on the CHATS-VASc score. If the CHATS-VASc score is high, the patient, even if he remains in sinus rhythm post-ablation, he should be on NOACs for life. Long-term antiarrhythmic therapy, amiodarone is possibly the therapy of choice for most of the patients except the ones who have no structural heart disease, in whom other drugs may be tried, but if nothing works, then amiodarone is the go-to drug in any case. Attention to good blood pressure control has been upgraded to class 1 from class 2A, whereas physical activity has been downgraded from class 1 to class 2. But I do think that physical activity management is also important. Obstructive sleep apnea management has been downgraded from class 2A to class 2B. And for stroke prevention, especially in patients who have had ICH, detailed discussion with neurologist or stroke specialist should be done, and these patients should be started on NOACs to decrease the chances of intracranial bleeds. This has been upgraded from class 2B to class 2A. Long-term oral anticoagulant therapy to prevent thromboembolic events may be considered in patients who have had post-operative atrial fibrillation after cardiac surgery, and this also again depends on the CHATS-VASc score, and this has been downgraded from class 2A to class 2B. Thank you. And I would like to point out here that these guidelines also say that beta blockers should not be used for AF prevention in as a pre-op medication for patients who are going non-cardiac surgery. Thank you. Thank you once again for inviting me for this talk.